So before we dive into this Q&A, since this program centers on coping with relapse and managing treatment side effects, how do you approach these first-time conversations with patients and their care partners who are facing relapse and potentially dealing with a new set of side effects due to the changes in their treatment regimen?
I think that's a great question, and I think there's a lot of things to consider. So I think the first thing that we want to think about when we're talking about patients having relapsed or refractory follicular lymphoma is that just because patients have relapsed or refractory follicular lymphoma doesn't always mean that they need treatment. So many patients, when they're initially diagnosed with follicular lymphoma, are going to go through a period of observation or watch and wait, where we know that they have follicular lymphoma, but they don't have symptoms of their disease. They don't have, a large number of lymph nodes involved, or their lymph nodes are not very large by the scans, and they don't necessarily need to be treated until they become symptomatic or have certain concerns from their lymphoma that's causing problems. So the same thing can happen probably more with relapse than necessarily refractory disease, but patients you may detect on scans that they have lymph nodes that are growing or that their disease has recurred, but they don't always necessarily need to receive treatment. Once you've identified that, yes, a patient requires treatment for their relapse or refractory follicular lymphoma, the next thing to think about is that patient and their disease. So what age is the patient? What were they treated with initially? Because not all patients receive the same initial therapy. So the decision about what they're going to receive when they relapse is going to be somewhat dependent on what they received for their initial therapy, what side effects they had from that therapy, and how they responded to that therapy. The next thing is going to be that there is not just one option at relapse. So really discussing the different options for those specific patients and what are the options, what are the side effects of those options, what is the treatment schedule of those options, because some treatments may have more toxicity, but they're time limited, whereas other therapies, may be continued till progression. They may have less toxicity, but over time, that's a toxicity that patients continue to experience on a daily basis. So really, talking to the patient about the options, what does the schedule of that treatment look like? Do they have to come in weekly? Do they have to come in once a month? And then again, the side effects and how that fits into side effects that they had with their initial therapy, how they tolerate that, or any of those side effects still there. For example, if a patient has neuropathy from their therapy, that might be something that lasts. And then, considering all those things and making an informed decision with the patient.
Okay, thank you. And these questions are in the perfect order because we have a question from Lauren asking you, what is the difference between relapse and refractory?
Okay, this is another great question. I'm sure all these questions are great, but when we think of relapse disease, we think of a patient who's had therapy, gotten a response to that therapy. That response has lasted, some time, and then their disease recurs. When we think of refractory, we think of that more as patients that have received a therapy and they haven't responded. Now, there's no standard definition of refractory. So we all agree that if a patient gets a treatment and their disease does not respond to that treatment, they're refractory to that treatment. But there's no defined time for which, if a patient has a treatment and responds to that treatment but has a short relapse, what's really considered refractory. In general, a lot of studies that look at a therapy say that if you've had it, like if you've had rituximab and you've relapsed within a 6-month time frame, that's refractory. But some studies use 3 months instead of 6 months.